our endocrine lecture today about male hypogonadism. We'll talk about hypogonadism as a general, but our focus will be on male hypogonadism because, of course, most cases of female hypogonadism is going to OBS and gyne. Is that clear?
Yes.
Okay. So we need to do an interactive lecture. Huh? I don't like this manner the lecture is going to talk while all are sleeping. So please be ready for question and answers. You ready? So by definition is hypogonadism. Hypo means low, gonads. What are the gonads? They are the testicle in males and ovaries in females. So if there is decrease in the function of these organs, we consider the person is hypogonadal. Regarding male hypogonadism, the main function of the testis is sperm production for fertility. The second is testosterone production. By which cell in the testis which produce testosterone? The interstitial cell of Leydig is the cell responsible for production of testosterone, and the seminiferous tubule is the one responsible for sperm production. So we will show now a cut section or histological section of the seminiferous tubules, which is the male bulk of the testis. The seminiferous tubule, all this is considered one seminiferous tubule, and this is another one, and this is another one. And in between the seminiferous tubules lies the interstitial cell of Leydig, which is responsible for release of testosterone. While the seminiferous tubule itself is responsible for the sperm production in different stages until the mature sperm. The mature sperm, it reaches the lumen of the seminiferous tubule, then it passes into the vas deferens, seminal vesicle, and so on. And more than 90% of the testis consists of seminiferous tubules. So the seminiferous tubules constitute the main bulk of the testis wall, while the interstitial cell of Leydig constitute less than 5% even from the testicular volume. As all our endocrine organs, the testis is under the control of the hypothalamo-pituitary axis, like the thyroid, the suprarenal gland. So what is happening in this axis is the hypothalamus is going to release the gonadotropin releasing hormones, and the gonadotropin releasing hormone is going to act on the pituitary. Which pituitary, anterior or posterior? Anterior pituitary, excellent. And the anterior pituitary is going to release the LH and FSH in the circulation, and the LH is going to stimulate the Leydig cell, the interstitial cell, in order to produce testosterone. Okay? And this testosterone is going to produce negative feedback again. On the other side, the FSH is going to act in the seminiferous tubules and produce sperms. But of course, sperms will not reach the brain. Okay, so this is going to produce another hormone, which is inhibin. And this inhibin will complete the feedback regarding the FSH and the sperm production. Am I clear? Okay. We will discuss the function of testosterone. Testosterone function depends on the stage of development. In utero, its function is to cause sexual differentiation into male sexual differentiation. If you review the sex differentiation or sex identity in utero, after fertilization, the male embryo will have XY chromosome. And on the Y chromosome, there is a certain point called testis determining factor. And this testis determining factor is going to act on what we call undifferentiated gonads. Undifferentiated gonads. And it will turn this undifferentiated gonads into testes. And then the testis itself starts to secrete testosterone. The testosterone acts on the urogenital tubercle. Urogenital tubercle, and it will turn it into male phenotypic sex. Is that clear? So that's what happened in our body. So testosterone here is responsible for male sexual differentiation. And at puberty, it is responsible for the development of secondary sexual characters and help to induce and maintain spermatogenesis, and it has its own effect on the muscle. It is going to increase the muscle bulk and the muscle strength, and especially the shoulder girdle muscle. It has its own effect on the bone. It increases the bone density, and it is a good stimulus for erythropoiesis in the bone marrow. These are considered the main function of testosterone. Then we will discuss the causes of male hypogonadism. Male hypogonadism could be due to causes in the testis or the cause in the hypothalamo-pituitary axis. If the cause in the testis, it is called primary hypogonadism. And in such case, you will find the testosterone low while the FSH and LH will be high. Okay? And if the cause in the pituitary and the hypothalamus, it is called secondary hypogonadism. And in such case, the testosterone low and the FSH and LH will also be low. Low or normal. Okay? Primary hypogonadism, the causes in the testes. What can cause testicular damage? Here, if the patient exposed to infection, especially mumps virus, mumps orchitis, the virus may attack the testicle, producing mumps orchitis. Or if the testis is exposed to radiation, and the previous lecture was about I think it is leukemia. So in acute leukemia, there may be testicular relapse. So they may be exposed to radiotherapy or cytotoxic drugs. And in such case, testicular function is going to be impaired. Then trauma to the testicle, whatever the cause, blunt injury or sharp injury, or patient who underwent bilateral orchiectomy, whatever the cause, whether it is post-traumatic or due to tumor in the testis, leukemia in the testis, and so on, or if there is an autoimmune antibody which attacks the testicular cell, and in chronic systemic illness as a part of the general condition is going to suppress the testicular function, as in case of chronic liver failure and chronic renal failure, and patient with HIV infection. Okay? Then the Klinefelter syndrome. Klinefelter syndrome, the cause here is chromosomal abnormality. There is an extra X chromosome. Normally the male phenotypic chromosome is 46XY. Here there will be an extra one, so you may get 47XXY. Another etiology is cryptorchid, the undescended testis, the testis which kept in the abdomen and doesn't descend into the scrotum. In such case, it will be exposed to the unusual high temperature in the abdomen. And this high temperature is going to suppress the testicular function. Then if there is enzymatic deficiency in the androgen biosynthesis, the androgen is one of the steroid hormone, and there is a long chain for synthesis of androgen from cholesterol. If there is any defect in the enzyme responsible for such synthesis, the patient will suffer from decreased androgen. And in some congenital disorders such as myotonia dystrophica, you studied neurology before? So when you study neurology, you come across an important case in neurology, which is myotonia dystrophica. In myotonia dystrophica, the patients usually suffer from myotonia, frontal baldness, testicular atrophy, and cardiomyopathy. So testicular atrophy could be a part of genetic syndrome, which is myotonia dystrophica. Congenital anorexia is congenital absence of both testicle, and varicocele if there is excessive veins, dilated veins around the testicle, it is going to raise the temperature around the testicle, and same manner it will suppress the testicular function. So those are the primary hypogonadism. Then we will shift to secondary hypogonadism. Secondary, as we had mentioned, that they cause lie in the pituitary and the hypothalamus, and in such case you may find isolated idiopathic hypogonadotrophic hypogonadism. Means the only deficient hormone in the pituitary is the gonadotropins. So it is called isolated. Idiopathic because up to this point we don't know the cause. This is what we call isolated idiopathic hypogonadotrophic hypogonadism. Then the Kalman's syndrome. What is this Kalman syndrome? Same as isolated idiopathic hypogonadotrophic hypogonadism, but associated with midline defect. Midline defect in the form of defect in the sense of smell, hyposmia, anosmia, or cleft lip and cleft palate. This is called Kalman's syndrome. Then we may find that the hypogonadotrophic hypogonadism is associated with other pituitary hormone defect that we call idiopathic hypogonadotrophic hypogonadism. Then the causes which mostly we encounter after puberty. If there is any lesion in the pituitary gland, for example, cellular or supracellular tumor, pituitary adenoma, going to suppress the FSH and LH, or for example, craniopharyngioma, same, cellular and the supracellular tumor is going to suppress the pituitary. And if there is infiltration of the thyroid gland, of the pituitary gland, for example, it could be infiltrated by abnormal cell in sarcoidosis, in eosinophilic granuloma, or it could be infiltrated by excess iron as in hemochromatosis. So the hemochromatosis patient is hypogonadal not because of the testicular dysfunction, but because of the pituitary infiltration. Same, infection and the trauma could affect the pituitary, and patient with critical illness, patient exposed to surgery, head trauma, or myocardial infarction, and in such case it will be temporary hypogonadism. It is a reversible process because this is the usual compensation, or this is the usual reaction of the body to stress. When your body is exposed to stress, is going to neglect and is going to stop all unnecessary function, and is going to maintain only the gland and hormones which are life-saving, especially the cortisol hormone. That's why in hypopituitarism, the last hormones to be affected is STH, while the first is the gonadotropins. It is considered at this point unnecessary function. So in critical illness, as we had mentioned, and in systemic illness, patient with chronic kidney disease, chronic liver disease, patient also having hyperprolactinemia, excess amount of prolactin hormone in our body is going to suppress FSH and LH, same patient with hypothyroid function. Any question at this point?
الهيموكروماتوز اكتر مش بتعمل deposition في testicle.
No, hemochromatosis causes deposition in the pituitary. The deposition in the testis in hemochromatosis of iron in hemochromatosis in the pituitary gland.
Not in testicle.
Not in the testicle. Any question at this point? Okay, we will move to the clinical presentation. The clinical presentation, it depends upon the age of onset. If the hypogonadism occurs in utero, as we had mentioned, that testosterone is essential for differentiation into male or female, so absence of testosterone results in ambiguous genitalia. You cannot delineate whether it is male sex or female sex. While before puberty, deficiency results in delayed puberty. You will not pass into the pubertal stage. After puberty, it will result in feature of what we call adult hypogonadism. Is that clear? What are the features of adult male hypogonadism? Again, if the prepubertal onset, it will produce what's called oncoidism. What will happen in the body of such patient? There will be lack of adult male hair distribution. There will be sparse axillary and pubic hair. From where comes this axillary and pubic hair? Yes, from the suprarenal gland, because the suprarenal gland has the zona reticularis, which is responsible for release of androgen. And there will be lack of temporal hair recession, which is characteristic of puberty. Then the voice will not change it. It will remain the infantile high-pitched voice, and the genitalia will remain infantile with a small penis, testis, and scrotum. And there will be increased fat deposition in the feminine parts in the hip and the side and lower abdomen. And again, there will be skeletal changes in the form of the arm span is more than the height by more than 5 centimeters, and the upper segment to lower segment ratio is less than 1. Okay, all this feature constitutes the oncoidism.
What's meant by oncoidism?
All this is the meaning of oncoidism. Huh? Then we will discuss if the patient after puberty develop hypogonadism. We will complain of such symptoms: decreased vigorous and physical energy, decreased muscle strength, and again, especially the shoulder girdle muscle. The sexuality, it will be reduced desire and erection, and even the volume of the ejaculate will be reduced, because the testosterone also stimulates the prostatic cell in order to produce a lot of secretion, which constitutes the seminal volume. There will be also mood disorders in the form of lack of motivation and depression and lethargy, and there will be also vasomotor and nervous changes in the form of hot flushes and sweating, same to what occurred in female after menopause. So sometimes we term this andropause. Andropause equivalent to menopause. Am I clear? So what are the physical findings expected to be? Diminished muscle mass, loss of the body hair, abdominal obesity, enlargement of the breast, what we call it gynecomastia, and on examination of the testis, you may find the testis is normal in size, because, as we had mentioned, that more than 90% of the testis are formed of seminiferous tubule, so it is unlikely to decrease in size. There will be also a metabolic effect due to decreased testosterone, because we had mentioned that testosterone has an extragenital effect in the muscle mass and the RBC's production and lipid profile. So there will be abnormal lipid profile. There will be decrease in the muscle mass producing osteopenia and osteoporosis, and there could be anemia, because we have mentioned that testosterone is an important stimulus for bone marrow erythropoiesis. Then we will give you a short notes about Klinefelter syndrome. The Klinefelter syndrome is the most common congenital abnormality in the primary hypogonadism. The male has an extra X chromosome, so you might get 47XXY, which is the most common, or you might get another extra X chromosome, meaning that there is two extra X, 48XXXY, or you may get mosaic 4, 46XY, 46XXY. What is this mosaic 4?
كروموسوم على كروموسوم.
No. Mosaic 4 is after the cell. So what happens in Klinefelter syndrome, what we call non-disjunction. Non-disjunction. Usually, during the metaphase of the chromosomal separation, each pair of chromosomes extend with each other, and every cell will go to one side. So non-disjunction means the two go to one side. The other will be deficient in that one. So if this occurs during gametogenesis, what is gametogenesis? The formation of gametes, the sperms or ovum. It will produce the classic Klinefelter, 47XXY. But if it occurs during embryogenesis, so the fertilization happens normally and results in 46XY. Okay? And then with this 46XY, it is going to divide. The embryo is going, cell line is going to divide. One cell line will suffer from non-disjunction, and the other cell line will have this extra chromosome. Okay? So you may get here 46XY, which is a normal, and this is going to divide into another cell, and you may get here 47XXY, and this is abnormal. So you have a mosaic of cells, mosaic of normal and abnormal cell. This is what we call mosaic Klinefelter syndrome. Here?
الكلينيكال بيكتشر بتاعتها هتبقى اقل شويه من
Yes, the clinical picture, it will be modified, not the same as the classic Klinefelter syndrome. Even he may look normal, even he may be fertile, as we will see here. So what will happen in Klinefelter syndrome, as we had mentioned, is that this during embryogenesis, the chromosomal 6 is very important. So this extra chromosome is going to affect the testicular function while in utero. So it will produce hyalinization and fibrosis of the seminiferous tubules. The seminiferous tubules will be replaced by fibrous tissue. Okay? And this results in decrease in the inhibin and will lead to feedback increase in FSH. And due to the disturbance in the amount of testosterone, decreased amount of testosterone, and there will be increased peripheral conversion of testosterone to estrogen. Usually male has 1% of estrogen and 1% of testosterone. With Klinefelter syndrome, testosterone is going to convert it into estrogen peripherally. Peripherally meaning in the fat. In the fatty cell is going to change testosterone into estrogen, and the disturbance of the ratio between testosterone and the estrogen in male is going to increase the breast size, what we call it gynecomastia. So we will find this person which have small testes and gynecomastia and he have female type of pubic hair pattern, which is the inverted triangle, okay? And there will be absent frontal baldness, and there is no secondary sex character. The beard and the mustache are less developed, and he could also suffer from osteoporosis because of the decreased amount of testosterone, and he is usually mildly impaired in his intelligence. He is not mentally retarded, but his IQ, they found it subnormal. This constitutes all the features of Klinefelter syndrome. So if you find a tall person with a small size testicle, gynecomastia, you should exclude Klinefelter syndrome. The investigation of any case of hypogonadism, you should do serum FSH, LH, and testosterone in order to differentiate whether it is primary or secondary. In primary, FSH and LH will be raised, while in secondary they will be low. You should ask also for semen analysis in order to detect if the affection involve only the interstitial cell or affect also the seminiferous tubules. You should ask for leukocyte karyotyping, meaning chromosomal analysis, to detect if the patient is suffering from Klinefelter syndrome. You should assess other pituitary hormones, because we had mentioned that the gonadotropins may be reduced either alone or associated with other pituitary hormones. Okay? And we had mentioned that increased serum prolactin also could cause hypogonadism. From where does this serum prolactin come? From the lactotroph cell. Where is it? In the anterior pituitary. Okay? Then you may ask for serum prolactin, iron saturation to exclude hemochromatosis, MRI brain in order to detect any brain tumor or brain lesion, testicular ultrasound to detect testicular size, any varicocele around the testis, lipid profile and bone densitometry in order to detect the secondary effect of decreased testosterone, usually in the form of impaired lipid profile and osteoporosis or osteopenia.
A normal size
Size of what? No. You have a lecture of hypogonia of puberty. You got a lecture of puberty. So how could we manage the patient with hypogonadism? You should treat the cause if possible. Okay? So if the patient had hemochromatosis, you should do what should we do? Iron chelation therapy or repeated venesection. If the patient has hypothyroidism, give him estrogen, eltroxin replacement therapy, and so on. Then you should give the patient testosterone replacement. The choice of testosterone, we have oral testosterone, transdermal testosterone, and intramuscular testosterone. Oral testosterone in the form of tablet, transdermal in the form of patches or gel, or intramuscular injections. The one which are commonly used is intramuscular testosterone. Intramuscular testosterone, either short-acting or intermediate acting or long acting. The one which commonly used is the intermediate acting testosterone. Testosterone and sabunate. And this is the usual dose from 250 to 300 mg IM every 3 weeks or 4 weeks. And the advantage, it is relatively inexpensive, about 3 to 4 pounds. And flexibility of the dose, you can increase or decrease the dose as required.
3 to 4,000? 4
4 pounds, 5 pounds.
4 5 جنيه ولا ايه؟
أيوه. So cheap then. Okay? Then any patient who is under testosterone therapy, we should monitor the side effect of testosterone. The most important is the effect on the prostate, because testosterone is going to increase the prostate size. So take care of benign prostatic hypertrophy. It may even uncover prostatic cancer. If there is any carcinoma in situ exposed to serum testosterone level, it may go and flush. It has its effect on the cardiovascular system, and its effect on hemopiosis is going to produce polycythemia. And what its effect on the liver? Liver, what?
Effect of it. Effect of it.
Effect of testosterone in the liver. Side effect of testosterone in the liver. It is going to produce cholestatic jaundice. So androgen, same like contraceptive pills, may produce obstructive cholestatic jaundice. So take care of any patient receiving androgen. You should keep an eye on the prostate and on the liver. Then if the patient suffering from testosterone deficiency only, and he is not aware about fertility, he don't care about the fertility, okay, give him testosterone sufficient. But if he desire for fertility, please help him for fertility management, and in such case, you may be in need for assisted reproduction. Assisted reproduction, meaning that you may search about the few number of sperms, take it and inject it into the ovum. So assisted reproduction could be a solution for this fertility problem. Then the remaining part is female hypogonadism. Same like male hypogonadism. It is decrease in the function of the two major functions of the ovaries, which are overproduction and estrogen production. And the same, the clinical picture depends upon the age of presentation. In adult, it will produce adult hypogonadism with premature menopause and osteoporosis. And before puberty, it will produce delayed puberty. And the causes, same like male type, either primary, means the cause in the ovaries, secondary in the pituitary and hypothalamus. In the ovary, the causes may be surgical removal, radiation, autoimmune arthritis, and Turner syndrome. Do you know Turner syndrome? Okay. So, secondary causes, secondary hypogonadism, cellular, same like male counterpart, but here we will stress on anorexia nervosa, because this is usually a disease which is linked to female. So patients with anorexia nervosa usually suffer from amenorrhea because of the disturbance of this X. And again, the girls which are exposed to stress, physical exercise and stress, especially the marathon runners and those who are participating in Olympic Games and are preparing for such championship, they are under physical and psychological stress. So again, the body will neglect these eggs at all and will stop the gonadal eggs. And so most of those girls are suffering from menstrual disorders. And in medical female students also, they may suffer from such disorders during exam days. Is that clear? Again, our body will neglect all unimportant function during the period of stress.
ممكن ياخدوا كونتراسيبتيف بيلز يا دكتور ايام الامتحانات؟
Puberty in girls is just a small hint, because puberty is it should be a separate lecture. Just will give you a small hint on puberty in girls. The appearance of secondary sexual characters, usually between 8.5 to 13 years. And the first pubertal event is a breast development. This is the first pubertal event, and the age of average 10 to 12.5 years. Okay, Then is followed by pubic hair development 6 months after breast development. Then later on there will be growth spurt. The young girl will be very tall. Huh? Then menarche will occur as a growth spurt wane, and at that time the final height will be standard. This is in summary the pubertal events in girls. The first pubertal event is the breast budding. The last pubertal event is the occurrence of menses. Then Turner syndrome, same as Klinefelter. It is a chromosomal abnormality, but here there is a deficient X chromosome, 45X0, and this will affect the ovarian function, causing ovarian dysgenesis. The ovarian tissue are replaced by fibrous tissue producing strix gonads, and these gonads cannot release estrogen, so there will be hypoestrogenemia. And so long as there is no estrogen, you will find puberty is delayed and the uterus is hypoplastic. Okay? There is other somatic changes which couldn't be explained by the defect in the testosterone, which are short stature with widely separated nipple. There is lymphedema. There is a webbed neck, low hairline, increase the carrying angle of the shoulder, a lot of somatic abnormality, and also they are exposed to many internal organ abnormality, especially the cardiovascular, producing aortic coarctation, and renal abnormality, may be renal agenesis, solitary kidney, duplex ureter, malrotated kidney. All such abnormality are common in Turner. Turner treatment, you should give her estrogen replacement to induce puberty, and at the age of puberty, give her cyclic estrogen and progesterone, same like contraceptive pills, to induce menses. And you may try growth hormone for short stature. Patients with Turner are eligible for growth hormone therapy even if their own growth hormone is normal. Is that clear? So growth hormone therapy should be given in order to gain height. You might ask for abdominal ultrasound to search for associated renal abnormality, and we ask for echocardiograph to search for associated cardiac abnormality. Okay, then the management of hypogonadism in female, same like male, treatment of the cause if possible. Estrogen replacement, you may need to give estrogen, cyclic estrogen and progesterone to induce menses. And if she is infertile and she's hoping for fertility, she may need for assisted reproduction. Thank you. Any question?
By aging.
Sorry?
By aging, the activity of the testes and then the sperm.
Stand up. Stand up and raise your voice. We have one question here.
By aging.
By aging?
By the sperm production and the activity of the testes will decrease. So there must be a certain range of age that we can diagnose as male hypogonadism.
Sorry, could you clarify your point, please? Because
Right.
no problem, I will help you. What is your point?
By aging.
By aging, okay?
And the men's getting older.
Yes. If the boy gets older, it means it's like
From adult to the older age,
yes.
the sperm production will decrease, and then the activity of the testes will at last decrease.
Okay.
So can we classify the men to have the hypogonadism?
يعني
مع الدخول في السن
ليه باي ايج اللي هو الاولد ايج ده ما بيعملوش هايبوجوناديزم.
By age, because this is a normal degenerative process. يعني after 70 and after 80, this is a normal degenerative process. Is that your question?
There may be a range of age that we can diagnose as the male hypogonadism.
Yes, of course.
So what the range?
Yeah, you can diagnose it in utero, after birth, before puberty, after puberty, in adulthood. Huh? Till elderly, age of 70 and 80, he is not aware about the testicular function. This is your question or no? I'm afraid I didn't answer your question. Is that your question?
No limits in the age.
No limits. This is a normal senile process. The testes get older like our body, our skin, our hair. So we cannot label him as hypogonadism. Is that clear? You are not satisfied. Any other question?
Doctor, is primary
Sorry?
hypogonadism
Yes.
with the adrenal androgen will be affected.
With?
Adrenal androgen will be affected.
Now, with primary hypogonadism, even with secondary hypogonadism, the adrenal androgen are out of control of the hypothalamo-pituitary adrenal axis.
So what control the adrenal androgen?
Nothing up till now. They don't know what caused adrenal androgen they even act at earlier age. At the age of 8 or 9, they start to secrete their androgen. So it is not surprising to find a young boy with 8 or 9 years and start to show mustache in his lips. This is because of the adrenal androgen.
دكتور هو كان عايز يقول هو بالنسبه اللي هو الهايبوجوناديزم ده بيبقى تستوستيرون انجكشن. برضه الاولد ايج لما يحصل له تستي.
لا طبعا. This is your question. Regarding testosterone injection.
بيتكلم راجل عنده 70 سنه مثلا.
No, you shouldn't give him testosterone at this old age, mainly because of the prostate. Because prostatic enlargement and the cancer prostate is so common in old age. So if you're going to give him androgen at this time, you may flush the prostatic side and may uncover carcinoma side of the prostate and increase in size. Is that your question? You are not satisfied, I don't think.
دكتور هو السوبرا رينال جلاند الاندروجين بتطلع منها. الاندروجين بتطلع من السوبرا رينال جلاند مش مسؤول عن اي حاجه بالنسبه لل
لا احنا قلنا الأندروجين بتاع suprarenal androgen responsible mainly for growth of hair, but it also share with the common goal of the androgen. فهمت وجهة نظري؟
في الفسيولوجي كان بيقول انها بتبقى مسؤوله عن الالكشن. في الفسيولوجي كان بيقول انها هي المسؤوله عن الالكشن، فده كلام مظبوط.
لا ده موضوع out of يعني we want to discuss it could be, but it is responsible of desire, even not erection. Erection is a vascular phenomenon. Okay? Take it as it is. Erection is a vascular phenomenon, while desire is a hormonal phenomenon. So it enhances desire. So sometimes they use it even in female to enhance desire. Okay? Here. Yes.